Good morning, everyone. I'm Melissa Geller. I'm a gynecological oncologist here at the University of Minnesota, and I want to tell everyone here this morning we're thrilled to have Britt Erickson. Dr. Erickson joined my division in 2015 upon completion of her gynecological oncology fellowship at the University of Alabama. In 2019, she received a Birch Award where she dedicated her research to really studying steroid hormone receptors in endometrial cancer under the watchful eye of Dr. Carol Lang, and since that time, Dr. Erickson's career has really taken off. In 2017, under support of Dr. Frank Andre, she became the PI of an NCI-funded cancer prevention grant that is using exemestane in women with early-stage endometrial cancer, or what we call complex atypical hyperplasia. As a result of this work, she submitted a protocol concept to NRG, which is our cooperative group, and is now the lead PI for a nationwide phase 3 study that's looking at the use of trastuzumab, or a combination of trastuzumab and pertuzumab, in HER2-positive advanced stage and early stage uterine serous carcinoma. In addition, she recently found out that her R50 has scored well, so this is basically a research specialist award for clinician scientists who will go on to help increase the number of clinical trials, both here at the University of Minnesota and at our community settings. Dr. Erickson is going to speak to you today about serous endometrial cancer, which, as many of you may know, unfortunately comes with a worse outcome for many of our patients. And so I will hand this over, and the title of her project or her presentation is Uterine Serous Carcinoma Updates and Unanswered Questions in Early and Advanced Disease. So thank you.
Thanks all, thanks for being here, and thanks Dr. Geller for that introduction. Okay, hang on one second. There we go. Here are my disclosures. So today, this is sort of an outline of the talk. I'll be talking for the next 30 or 40 minutes. I'd like to give some updates, first of all, in the epidemiology of uterine cancer, and specifically uterine serous carcinoma, including a brief discussion in racial disparities, which is a really interesting and important topic. I'd also like to review some updates in the genomic landscape of uterine serous carcinoma, and then discuss where we are in terms of primary adjuvant treatment, as well as I think what is the more exciting part, which are some new targets in uterine serous carcinoma, which include HER2, P53 or WEE1, and then also immuno-oncology targets. So I'll start with the CDC statistics, which break down solid tumors by male and female genders. In 2023, it's predicted that uterine cancer will be the 5th most common cancer among females. And interestingly, in the bottom right panel, you'll see that we always talk about ovarian cancer as being the most deadly gynecologic malignancy, but it's actually predicted now that uterine cancer will surpass ovarian cancer in terms of number of deaths due to disease. I want to do a little nomenclature for those of you who may not be as familiar with uterine cancer. First of all, we use uterine and endometrial cancer sort of interchangeably, the endometrium being the lining of the uterus. The old paradigm for thinking about endometrial cancer was very binary. We talked about what was called type 1 uterine cancer and type 2 uterine cancer. So type 1 is the most common type with what we call endometrioid histology. It's typically low grade, ER or estrogen receptor positive, and it's usually associated with high estrogen states, most notably associated with obesity. And it affects patients of all ages and all races. Type 2 uterine cancer is our more aggressive histology. Specifically, this is where uterine serous carcinoma falls. It's not usually ER positive. It doesn't seem to be associated with estrogen exposure as much. It's more common in patients that are of older age, and actually, as I'll show, more common in non-white race. That being said, since 2013, with the TCGA paper on uterine cancer, we now have a new paradigm to think about how we classify this disease. And so I'll briefly tell you sort of what this paradigm is, mainly just for a language, or just to give an update on this. So there's 4 subtypes now of endometrial cancer based on the TCGA data. The first subtype we call the POLE ultramutated. This is the least common type, and interestingly, these tumors have a lot of mutations and actually are very sensitive to treatment, so they actually do quite well. The other subtype is called microsatellite unstable or instability high. So think of this a little bit like the colon cancer paradigm. These patients tend to have more aggressive tumors, although they do respond to PD-1 and PD-L1 inhibition. The largest category is called copy number low. This is kind of that old type 1. These are endometrioid type tumors and tend to have a better prognosis. And then finally, on the right-hand side there, I think I have a mark here, is the copy number high group. And this is the group now that really contains mostly these uterine serous tumors. The hallmark is high genomic instability with likely driver TP53 mutations in all of these tumors, and they tend to be TMB low. So the bottom left graph, you can see that survival curve, and patients with the copy number high tumors have the worst survival. I'm going to bring up this old graphic from 2006 because I think it does point out that uterine serous carcinoma, when we think of all the endometrial tumors, represents about 10% of uterine cancers. But unfortunately, it represents about 40% of uterine cancer deaths. So although we consider this a rare tumor, focusing on this and trying to improve therapy in this, I think, is really what's going to move the needle in terms of improving outcomes for endometrial cancer. So this is uterine serous carcinoma is a rare, aggressive, and poor prognostic subtype. Like I said, it represents less than 10% of all cases, but 40% of all cancer-related deaths. And I haven't mentioned this yet, but about half of patients have extrauterine spread at the time of diagnosis. I do want to talk a little bit more about the epidemiology of uterine cancer in general, because I think there's some interesting data that's emerged. So this graphic is from 2019 and depicts what we call the corrected rate of endometrial cancer. So traditional data didn't always correct for the rate of hysterectomy in a population, but you can imagine that that's an important thing to account for. So in this first panel, you can see that since 2000, in general, the rate of uterine cancer has been increasing by about 0.5% per year. Panel B shows endometrioid, or that type 1, the low-risk tumors. This really hasn't changed over time. The incidence is about the same. So the increase in incidence is really due to these type 2, these non-endometrioid, these copy number high tumors. And you can see about a 3% increase in incidence per year since 2000. And more specifically on that, if we look at racial differences in this, so this first panel shows that maroon is non-Hispanic Black patients and the blue is non-Hispanic white patients. And you can see that there's increase in incidence among all races, but in 2007, the incidence in non-Hispanic Black women was actually higher than in white women, and this was a big change. And moreover, there is an alarmingly high incidence of non-endometrioid, or these high-risk tumors in Black women, as represented there by that maroon line. So why is this? Why are the rates increasing? You know, our line that we've sort of been saying in GYN oncology for a decade or more, or even a couple decades, has been, well, this is all due to obesity. And I like to show this slide because I think it underscores the idea that there's much more to the story than obesity. So on the left is the CDC graph that you've all probably seen about obesity prevalence, and you can see the states that have the highest obesity. And I've yet to get an explanation on this, but on the right-hand side are the new incidence of endometrial cancers, and you can see that those do not overlay. And there's definitely more to the story than just sort of pushing this all on rising rates of obesity in America. So what are those things? We don't know yet, is the reality. It's very understudied. You may have seen this article come out in the New York Times that referenced an important NCI study that was published this year that actually talked about use of hair straighteners and up to a 4 times increased risk of uterine cancer. So I say this only to say that there's probably some environmental exposures, some endocrine disrupting compounds potentially, and other things that we just don't understand that are driving the increased incidence. So let's move on to the genomic characterization of uterine serous carcinoma. So this study looked at over 2,000 uterine serous tumors and performed comprehensive genomic profiling. And what we knew and was confirmed by this study is that uterine serous cancers have very high rates of P53 mutations. That's the first bar on the left, so over 90%. In general, these tumors are microsatellite stable. They're low TMB. About 1 in 5 are LOH high, which is something we often talk about in other gynecologic cancers. And the major alterations are noted in those genes. So the PIK3CA, CCNE1 amplification, PP2R1A, and there's an ERBB2 in there as well. So, and those lines, the blue are the uterine serous and the red are the endometrioid. So you can see there are different genomic profiles in serous and non-serous tumors. How does this help us better understand some of those racial disparities? Well, the same study looked and based on SNP analysis categorized the tumors as being from patients associated or having African ancestry versus not having African ancestry. And they did see some genomic differences. It's hard to know what the clinical implications are on these, but some statistically significant differences in lower PIK3CA mutations, higher CCNE1 amplification, and lower PPP2R1A. So let's move on and talk about how we treat uterine serous cancer. So I should have warned you that this was going to be definitely a more clinical talk. I'll try not to talk too much about surgery. I only have one slide about surgery. But the standard treatment for uterine serous carcinoma, as is for all uterine cancers, is hysterectomy and surgical staging. It really remains the standard of care. We've moved towards doing what are called sentinel lymph node mapping and removal for all of our endometrial cancers. And we do favor biopsying the omentum and collecting pelvic washings for these types of tumors. For patients with advanced stage disease, surgical debulking or removing as much tumor as we can is the standard, and we often give neoadjuvant chemotherapy in patients who have very widespread disease. We sort of have extrapolated from a lot of data in ovarian cancer. And I did want to take this opportunity to show one of my favorite pictures from the operating room, so I want you to picture for a minute a surgeon in the operating room doing a complex hysterectomy, and then I will show you our surgical team. This was just over a year ago. On the left, it was our, yeah, isn't that cool? On the left is our anesthesiologist. I'm second to the left. And then our fellow, our senior fellow is next to me. And next to her is our senior resident. So all four of us were very pregnant. And we did this uterine cancer staging and patient did well. And now all the fetuses are on the outside. So despite outstanding surgical care, one of the unfortunate things about uterine serous cancer is very high recurrence rates. So up to 40% of patients with early stage disease will recur, and up to even 95% of patients with advanced stage disease will recur. So this really points to the fact that surgery is not enough for this cancer. So what do we do? Well, I won't bore you with all of our trials that we have in GYN oncology that help guide our therapy. But I do want to point out that uterine serous carcinoma has, unlike a lot of great trials in breast cancer, we really have lumped all types of uterine cancer together when we've studied adjuvant chemotherapy, which means that uterine serous carcinoma has represented about 15 to 20% of patients really on all of our notable trials, which is great because we can extrapolate and use that data, but it also we've sort of failed to really identify what might be more appropriate for uterine serous carcinoma. So these trials, as well as some retrospective data, have all pointed to our friends carboplatin and paclitaxel as being our primary adjuvant treatment for USC. And just to show one demonstration, this was our most recent GOG or GYN oncology group trial, or cooperative group trial, which tested the addition of radiation therapy to chemotherapy in patients with advanced uterine cancer. Did not show a benefit in terms of survival. And you can see that serous carcinoma was about 18% of patients. So that's what we have right now, is to sort of extrapolate from these larger trials. But I believe strongly that we should be studying uterine serous carcinoma as a separate entity. It has a different appearance, as I've described, different epidemiology, much different clinical course. And what I'll get into now is really different molecular targets and differential responses to chemo, radiation, and even targeted therapies. So let's talk about the more exciting things, which are targeted therapy and uterine serous carcinoma. So the molecular alterations that I want to talk about today specifically are HER2, which is likely very familiar to many of you in the audience, P53, and then also some data on immunotherapy and anti-angiogenesis in USC. So specifically, we'll be talking about trastuzumab, pertuzumab, and newer ADCs. We'll be talking about WEE1 inhibition, and then the combination of pembrolizumab and lenvatinib. So let's talk about HER2. There's probably people in the room that could teach me a lot about HER2, but we know that this is a really important target in a lot of solid tumors. It's encoded by the ERBB2 gene and part of the receptor tyrosine kinase family. Notably, it primarily dimerizes with itself and the other HER receptors and activates multiple pathways that are responsible for things like proliferation, differentiation, and apoptosis. We know that when HER2 is amplified, it's typically overexpressed and then constitutively activated. And this has really been highlighted in really landmark research in breast cancer, but also gastric esophageal or gastroesophageal, head and neck, and now GYN cancers as well. There are also some ERBB2 mutations, some more pathogenic than others, that may also represent an opportunity for targeted HER2 therapy. So what do we know about HER2 and uterine serous carcinoma? Like, what is the prevalence? This is actually a much harder question than it seems. It really depends on what part of the tumor you're looking at, what type of test you're looking at, and then which guidelines you're using. And for those of you who do IHC and know that, and do some of these testing, you know that it's more variable than it might seem. I actually had to make this table for myself that I keep in my office. On the top, there's different columns for different types of HER2 testing or HER2 interpretation guidelines, including the breast 2007 guidelines, the 2018 guidelines, and the gastric 2016 guidelines, which are a different set of guidelines. And they vary in terms of the sequencing of immunohistochemistry and in situ hybridization, the definition of 3+ on IHC, and then even the definition of what the FISH or what in situ hybridization amplification truly is. So a lot of different variables here in terms of testing. The other thing to note about uterine serous carcinoma is it's more like gastroesophageal cancer in terms of the HER2 staining. So in breast cancer, there tends to be more all parts of the tumor tend to look the same, whereas in USC, we see a lot of variability in staining. So this is some imaging from Dr. Buza, who's a pathologist very interested in this at Yale, where she demonstrated 3+, so complete membranous staining in this diagram. But here you see more weak to moderate staining in this what's called a basolateral pattern, which is less common in breast, but more common in endometrial and gastric cancers. Some heterogeneity of expression here, and then lack of apical membrane staining here. So hopefully someday we'll have our own guidelines of interpretation, but right now it's just important to know that it's not as straightforward as some of the breast, at least in the IHC. So again, what is the rate of HER2 positivity? It's really variable. So this table shows anywhere from less than 5% to up to 60%, depending on what study was done and probably the methodology and interpretations. So I became interested in this because I thought these numbers were very confusing, why there was so much variability. So I worked with one of our residents and we actually studied HER2 in a large cohort of patients with uterine serous carcinoma. We used actually the Caris platform and identified over 2,000 patients with USC tumors. And for all tumors, we had them perform NGS, immunohistochemistry, and in situ hybridization, so we could really get a sense in a large cohort of what the rates of positivity were. And then we compared them among platforms. So you can see here this bar graph that our rate of HER2 positivity varied depending on the testing platform. So it was as low as 10.5 with NGS testing using an amplification of 6. And then IHC was 12% using the 2007 guidelines, 16% using the 2018 guidelines. And we had the highest rates of HER2 positivity by using in situ hybridization. So again, these are all the same tumors, just tested with these different platforms to get a sense for how these platforms perform. We found, though, that when we compared immunohistochemistry versus in situ hybridization, that there was actually high concordance with good sensitivity and specificity. When we compared KISH testing versus NGS, though, we did find a much lower sensitivity. So in other words, there were quite a few patients or quite a few tumors where the NGS testing was negative, but KISH was positive, suggesting that NGS is reliable, but may not be the ideal testing platform right now. So let's talk a little bit about HER2 prognosis. We know that in breast cancer, at least prior to HER2 targeted therapy, these tumors tended to be more aggressive. So what do we know about this in uterine cancer? Well, the initial data was actually really conflicting and didn't necessarily show that HER2 tumors did worse, but that was really because most patients with uterine serous carcinoma recurred anyway. So it was very conflicted by, or very confounded by the histology itself. So we worked with our colleagues at Hopkins and Yale and actually did this study where we examined HER2 just in early stage uterine serous carcinoma. So specifically, we looked at patients who had surgically stage 1 uterine serous carcinoma. And we found a 23% rate of HER2 positivity based on immunohistochemistry with reflex to FISH testing in equivocal cases. We found that HER2 was associated with LVSI. And importantly, we found that in patients who had HER2 positive stage 1 tumors, they actually had a 50% recurrence rate compared to a 17% recurrence rate in HER2 negative tumors. And all these patients received adjuvant chemotherapy, I should note. So this corresponded to adjusted hazard ratio of 3.5 for patients with HER2 positive tumors and an adjusted hazard ratio of death of 2. So significant prognostic biomarker in early stage uterine serous carcinoma. So how about targeting HER2? Lots of lessons we can learn from breast cancer and targeting HER2. There was actually early work done. This isn't like a new concept in gynecologic cancers, but unfortunately our early trials really were not very impressive in terms of targeting HER2 in uterine serous carcinoma. Weekly trastuzumab was trialed with a 0% response rate. There were many criticisms of that trial, however, with actually a low percentage of uterine serous carcinoma cases and a statistically underpowered study. Daily lapatinib, which targets multiple EGFR family receptors, actually demonstrated a 3% response rate. So when these studies came out, it was sort of like pushed aside, like maybe this isn't going to be very helpful in uterine cancer. However, thankfully, people did not give up. Dr. Fader and her team published this really landmark, small but landmark study in 2018, where they recruited 61 patients who had advanced stage HER2 positive uterine serous carcinoma, and they used IHC for inclusion based on the 2007 guidelines. Patients were randomized to receive carboplatin and paclitaxel or carboplatin, paclitaxel, and trastuzumab with trastuzumab maintenance. So very similar to the early breast cancer trials. But impressive that they were able to accomplish this in a rare tumor. And although the numbers were small, this study did show an improvement in progression-free survival. And you can see on the upper right, those are patients who have newly diagnosed chemo-naive disease. And on the bottom right, those are patients with advanced recurrent disease. So there was the most notable difference in both progression-free survival, and I'll show you overall survival in patients with newly diagnosed HER2 positive uterine serous cancer who received trastuzumab in addition to chemotherapy. So here are the overall survival graphs. So the conclusion is that the benefit of trastuzumab was primarily in newly diagnosed patients that showed an improvement in PFS from 9 to 14.8 months, so improvement in progression-free survival, and an improvement in overall survival of 21 versus 32 months. So this was a big deal to finally have a trial specifically in uterine serous carcinoma that actually showed a survival benefit. So what's next? Well, this is when I sort of got involved with the study team. And as Dr. Geller mentioned, we've now opened a large cooperative group trial called NRG GY026. The title is a bit of a mouthful, but I'm going to read it. This is a phase 2/3 study of paclitaxel and carboplatin combined with either Herceptin Hylecta, which is trastuzumab in a hyaluronidase solution, or pertuzumab and trastuzumab, also known as Phesgo, in a HER2 positive stage 1 through 4 endometrial serous carcinoma or carcinosarcoma. So I am the PI of this trial, which is exciting under the mentorship of Dr. Fader, and we have a wonderful research team that's finally gotten the study open and accruing. So we're looking at patients who have newly diagnosed chemo-naive, non-recurrent, all-stage HER2 positive endometrial cancer, and that was born out of some of that work we did of early stage HER2 positive disease. We're stratifying based on stage, histology, and plans for brachytherapy. Patients are randomized to either receive standard chemotherapy, to receive chemotherapy with Herceptin Hylecta, which is a subcutaneous formulation of Herceptin, for those who may not be familiar with that, with up to a year of maintenance. And then arm 3 is a combination of trastuzumab and pertuzumab called Phesgo, which is also a sub-Q formulation, and patients will be receiving that for up to a year as well of maintenance. We're starting with a phase 2 and hopefully expanding to a phase 3 if we see some encouraging results. Our target enrollment is 525 patients. And importantly, we're really trying to ensure that we have enrolled up to 26% of Black patients. Again, this goes back to the idea that we will not make progress in this disease if we're not including the patients that are most affected. So let's move beyond trastuzumab and talk just for a little bit about some of the newer HER2-directed therapies. So much really impressive research. I wish I could say these graphs were from uterine cancer, but they're not. So the upper right graph is from the Destiny breast trial, and then the Tula breast trial on the bottom right. So we're really seeing a lot of impressive data about antibody drug conjugates in HER2-positive breast cancer and other solid tumor malignancies. So you may be familiar with these three drugs, which I'll talk about briefly: TDM1, trastuzumab duocarmazine, which has an alkylating payload, and then trastuzumab deruxtecan, which has a topo-1 inhibitor payload. So these drugs have been looked at in uterine serous carcinoma. Not a lot, but there is some data out there. So first, looking at TDM1, which was sort of the original antibody drug conjugate in breast cancer, there was some good in vivo and in vitro rationale for its use in HER2-positive serous carcinoma. And GYN cancers were included in some of the initial, what we call basket trials, studying this drug. The first trial had a 0% response rate, but a more recent trial, which included 18 endometrial cancer patients, had an overall response rate of 22% with 2 complete responses. And there are phase 2 trials underway in uterine serous carcinoma with this drug. I did want to highlight one of them because it happens to be open here at the University of Minnesota. This is called the EndoMap trial, which is actually it's a biomarker-driven clinical trial that's testing various combinations of atezolizumab with different drugs depending on biomarkers of the tumor itself. So patients with recurrent endometrial cancer, we send a biopsy to Foundation 1, and then receive biomarker testing results, and then they get not randomized, but placed in a cohort based on those results. So I just wanted to point out that our cohort 4, if patients have a HER2 alteration, they are put into cohort 4, and they receive TDM1 in addition to atezolizumab. So I'm the site PI of the study. Dr. Slomovitz is the national PI, and I did want to report that we happen to be the top enroller and accruer in this trial. At least, I don't know if this is totally updated, but we appreciate the Cancer Center's support of this really important work. So trastuzumab deruxtecan has really emerged as like a really impressive drug in breast cancer based on its mechanism of action and the way its payload has some bystander effect as well. It has been studied in preclinical data in uterine serous carcinoma, and there are some trials underway, including a phase 2 study with a dedicated endometrial cohort, as well as a phase 1 trial out of Dana-Farber that's actually combining it with olaparib in a uterine serous cancer expansion cohort. And again, so for duocarmazine, promising preclinical data in uterine serous cancer, phase 1 basket trial that included 13% of it, or 13 patients with endometrial cancer with about a 40% response rate, and some trials underway, mainly in Europe actually, for this specifically in HER2-positive uterine serous cancer. So I'm not expecting you to remember all this, but sort of the point is to say thank you, breast cancer colleagues, for letting us steal all of your ideas. And we're really hoping to move some of these drugs into HER2-positive uterine serous carcinoma. So I'm going to briefly talk about 2 other targets, and then I'll be done for the morning. So as I mentioned at the beginning of the talk, the majority of USC has a TP53 mutation. And so there's been interest in WEE1 inhibition and synthetic lethality in uterine serous carcinoma. So WEE1 regulates the G2M checkpoint, and cells with P53 mutation kind of inherently have loss of their G1S checkpoint. So that increases replication stress and then increases the dependence later on, as you can see in the circle, on the G2M checkpoint. So, sort of utilizing the P53 mutation in a synthetically lethal fashion. So there was a phase 2 trial that used the drug called adavosertib, which is a WEE1 inhibitor, and there was promising activity in this. Again, the reason these trials are great is because these are only patients with uterine serous carcinoma. So this is really new to really have these trials where we're only including these patients. The overall response rate, so based on the plot on the left, so each of those is a patient, and you can see when their tumor decreases, the bar graph sinks. So there was a response rate of 29%, a clinical benefit rate, so that includes patients with stable disease, of 50%, and a duration of response of about 9 months. So this was exciting and promising. There are a lot of toxicities with this drug, notably GI toxicities, so it is a bit to manage. There was a high partial response rate, and there was then rationale to continue investigating this. So there's now a larger phase 2 trial called the Adagio trial. We tried really hard to open it here. We won't get into that today, but hoping we'll see some ongoing responses for this drug. And ideally, we'd love to identify some biomarkers of response as well. Finally, I wanted to talk about the combination of a drug called lenvatinib and pembrolizumab, as this is becoming more common as well in uterine serous carcinoma. As many of you may be aware, pembrolizumab is a monoclonal antibody against PD-1, and it's already been approved as monotherapy for MSI-high endometrial cancer. So similar to, it's actually any solid tumors that are MSI-high, so notably colon and endometrial. Lenvatinib is an oral multikinase inhibitor that has multiple targets. And so the idea with these trials was to combine this to really increase the efficacy of IO therapy in microsatellite stable endometrial cancer. So Keynote 147 was a phase 1/2 study to evaluate this combination in patients with advanced tumors, and there was an endometrial specific cohort. So patients received lenvatinib daily, pembrolizumab once every 3 weeks. I won't go through all this eligibility criteria, but here again is the plot showing the response. So again, each of the columns is a patient on this trial. And the colors represent different histologies of endometrial cancer. So all patients in this trial had uterine cancer. And then the colors, you can see the red are patients with serous adenocarcinoma or uterine serous, and the blue are endometrioid. There was also some clear cell carcinoma as well. So again, these are patients who have progressed after primary chemotherapy, and in general, traditionally response rates to chemotherapy in this setting are about 5 to 10%. So that's kind of what our baseline was going into this trial. And so impressively, we saw for all patients, all 108 patients, an overall response rate of 38.9%, in both proficient and deficient mismatch repair tumors. So specifically in uterine serous carcinoma, there were 33 patients on this trial, and there was a response rate of 40% and a clinical benefit rate of 60%. So again, this is compared to like 5 to 10%, which was our baseline going into the trial. So this really, although this is a toxic regimen that is, I think, hard to manage for a lot of patients, it really represents, we now have FDA approval for this combination, really the first targeted therapy that really has an impressive clinical benefit rate. So I'm going to wrap this up a little and allow some time for questions. But in conclusion, I hope I've demonstrated to you and maybe educated you if it's a tumor you're not as familiar with, that uterine serous carcinoma is increasing in incidence and is significantly contributing to racial disparities in endometrial cancer outcomes. Unfortunately, data specific to uterine serous carcinoma is limited in guiding our upfront management decisions, but hopefully with our new NRG 026 trial, we'll be getting some information specific to this tumor type. We know that HER2 is a prognostic biomarker and a therapeutic target in the upfront setting, which we're hoping to expand in the future. And newer targets include P53 or WEE1 inhibition with adavosertib and other WEE1 inhibitors, an IO-TKI combination like pembrolizumab, as well as the newer HER2 ADCs. These are encouraging targeted therapies for recurrent disease. So I'd like to thank my collaborators and mentors here at the University of Minnesota, including Dr. Geller, Dr. Lang, Dr. Khalifa, and everyone listed here, as well as collaborators in some of our research at Hopkins and at Yale. And thank you for listening today. I appreciate being able to be here.
All right, we're ready to take questions from the floor.
Hi, is this working?
Yeah.
I'm not working. You're really wonderful talk. So I was wondering if in your clinical trials you're collecting biospecimens like blood, serum, and urine, because I think you're positioned uniquely to try to understand cancer etiology by linking up with the biomarker people and exposure biomarker people in the carcinogenesis program.
Yeah, that's a great point. It's so important that we have biospecimens in these trials. We are collecting tumor for the large NRG 026 international trial. We are collecting tumor, FFPE, and blood. It's very difficult for these large NCI trials to get more biospecimens funded and collected when you're doing international work. But we do have some plans to at least do some HER2 testing to correlate with response based on different testing platforms. And some ideas for what we're going to do with some of the serum and blood work, but we're not collecting urine. I think that's a great idea.
Yeah, there's still a lot you could do with the serum.
Okay, we should
We should talk.
Let's talk. Look forward to it. Thanks.
All right.
Great talk. So the JCO paper that you were describing that serves as the foundation for the phase 3 study, if I remember correctly, the definition of HER2 was a fish-based assay and strong IHC staining. Is that?
They started with IHC, so 3+ IHC based on 2007 guidelines. And then if it was 2+ or equivocal, then they did fish.
Okay, and then is that the exact same definition of the biomarker that's being used for the phase 3 study?
No, it's different.
And does that matter, the strictness of the definition of HER2 alteration?
We don't know. So what I've learned about biomarkers and all this, and I think the reason that breast cancer has just gone leaps and bounds ahead of us is because we've been able to not just say positive, negative, but to correlate how positive, how negative, and by which assay with response to HER2 targeted therapy. And we haven't done that at all. And so we had to make a lot of decisions when designing this trial. Should we be really inclusive about HER2 testing? Should we be really strict? But we just didn't have enough data to drive that, to be honest with you. And so for ease of use, we wanted to use the more recent guidelines, 2018. And we did decide to include NGS testing actually so if positive by NGS, they are included in the trial, which is not validated yet. But there was really a push to try to be as inclusive as possible because it's a rare tumor. So it was a real balance of that. But there's potential risks in doing that too.
Hang on. Just raise your hand if you've got a question.
Britt, great talk. Thank you. I wanted to ask you, can you speak to us a little bit about your inclusion for non-white participants in GY026? Because I think what you're doing in that and the numbers you presented to really try to be inclusive of that population is important for all of us doing clinical trials.
Yeah. I mean, it's a goal that we set forth really early in the trial and wrote it into the trial in terms of like the importance of that, because I think you could argue the trial will fail if we don't, even if we get results, if we don't include the patients that, like I said, that are the most affected by this. How to do that has been a bit of a work trying to figure this out. So we do have we call it disparities co-chair on the trial, which has been important in terms of having someone sort of dedicated to thinking about this and working through it. We're working with some community organizations that have networked patients with uterine cancer to try to get the word out, that specifically target or that try to get the word out to Black patients and other minority patients. And then there are groups within the NCI, there are sites that have higher populations. Trying to convince them to open it is a little bit more challenging, but that's also something that I'm working on as well. So we'll see. We're looking at that target carefully because, again, I feel very strongly that that's an important part of the study.
Britt, that was a great talk. So some of the things you commented on were very similar to the pathway, breast cancer and breast cancer surgeons figured things out, particularly in the adjuvant setting. So the next thing, well, a long time ago, the breast surgeons decided, well, let's give it in the neoadjuvant space. And I think that has become the standard of care now for lots of subtypes of breast cancer. So do you guys talk about that in NRG about your trial is a big trial, rare disease, but have you talked about neoadjuvant and secondary endpoints other than
Yes and no. I think the paradigm is a little different in terms of how we order surgery and adjuvant therapy. Doesn't mean it can't shift in the future, but oftentimes these patients are symptomatic and bleeding and need a surgery in early stage disease, which is, I think, very different from the approach in early stage breast cancer. So it's hard to imagine that paradigm changing and not doing a hysterectomy on a patient that's having bleeding. We are including in the 026 trial, we're not including planned neoadjuvant patients, just study design and the way the statistics worked out. But I do think that that will be extrapolated for advanced stage disease if this trial is positive, that we would use it in an advanced stage neoadjuvant setting. But I don't know if it's really going to move into an early stage setting as quickly and in the same way as breast.
Second question, are you talking, thinking about HER2 low, particularly for deruxtecan type studies, and is that moving in the gynecologic oncology world of opening up that type of ADC to everybody?
I mean,
That's what's happening in breast. There's actually
right.
a trial now for HER2 zero
Yep.
that will test TDXD.
I mean, I think as soon as we all heard that at ASCO, that was like our first thought is, okay, what percentage of our patients have HER2/1 expression at least, and can we? And there is, as I mentioned, a expansion cohort for endometrial specific that is happening. I don't know if they're enrolling yet, but that's the plan. It's like a part of the Destiny trial. So yes, there is excitement in that. We haven't really proved, I mean, I think there's an assumption that it'll probably work, but the reality, this isn't the same as breast. And so we haven't totally proven the first step yet, but we are, yes, moving into these ADCs in low expression.
Do we have any more questions for Dr. Erickson? All right, let's give her a great thank you and for a great talk.